Welcome back to Do or Do Not. For those of you who haven't realized, we changed to a monthly format. On today's episode, we welcome Kim Wolf, DO. Kim is a pediatrician and cranial osteopath. She trained at Nationwide Children's Hospital and is currently Director of Pediatric OMM and Associate Professor of OMM at Touro University College of Osteopathic Medicine. Today, she will share with us her love for pediatrics as well as her love for osteopathic medicine. She'll tell us about cranial osteopathy from its origin to where it becomes an important modality in the treatment of children today. This is a don't miss episode. My name is Dr. Ian Storch. I'm a board-certified gastroenterologist and osteopathic physician, and you are listening to Do or Do Not. If you're interested in joining our team or have suggestions or comments, please contact us at doordonotpodcast.com. Share our link with your friends and like us on Apple Podcasts, Facebook, Twitter, and Instagram. We hope you enjoy this episode.
My name is Suzanne Chaar, and I'm a third-year medical student at Ohio University Heritage College of Osteopathic Medicine. And I have the pleasure of interviewing Dr. Kim Wolf. Dr. Wolf, welcome to the Do and Do Not podcast. How are you doing today?
I'm doing well. Thank you so much for having me.
Can you share what is the origins of cranial osteopathy? Where did it start and how does concept develop over the year?
Cranial osteopathy, it's credited to William Garner Sutherland, who was a student of A.T. Stills. And really, the famous story with how he came up with this concept was that he was studying anatomy and specifically looking at a skull and what's known as a Bouchain skull, which is kind of a skull that's been like blown apart. They used to literally put beans inside the skull and add water, and the pressure from that would open up the skull and separate it at all its junctions. And he was looking at it and he saw the different shapes of the sutures of the skull where the bones connect and said that they were shaped and beveled like the gills of a fish, which that bevel let him know that there was motion happening at that joint. And that's where sort of this idea came from. And from there, he went on and really studied this. There were other people at the time working on this model as well, Beryl Arbuckle, Charlotte Weaver, but and so much of all three of their work is really integrated in, but William Garner Sutherland is the main one credited with this work.
Do you think A.T. Still, who found the osteopathy in general, ever imagined these techniques and like cranial osteopathy will exist?
Yes. And I'm honestly not convinced that he wasn't doing it. He was notorious for not really ever describing what he was doing. He was big on demonstrating what he was doing, but he never wanted a technique manual. He never wrote down word for word, this is what you should do. It's more his philosophy and his studies of anatomy and what he saw and studying the body in his writings. And so some of my mentors that I've worked with over the years have said that they think that he probably did do this because it wouldn't make sense given his philosophy that we should treat the whole body to not look at the head. But again, it wasn't a primary focus of his teachings, but there are many that believe that he was in some way doing this or that this was not a far-fetched concept for him at all. And so, just how I'd feel if one of my mentees took something of mine and ran with it and took it to the next level and it was going to better more people. I'd like to think that he was proud and excited about that and excited to see the expanding osteopathic concept.
Yeah, absolutely. So your journey is specifically into pediatric OMM, which is really unique, especially the cranial aspect of pediatric OMM. How can you walk us through how you first encounter cranial concepts, and how did you decide to really focus on that specific topic during your career?
Yeah, so I'm a pediatrician by training, and I'm exclusively trained in pediatrics, so I didn't do an ONMM, any formal training in that. And I always knew that OMT would be a part of my practice. I intentionally chose osteopathic school because of the OMT, and that really resonated with me. And I love that in pediatrics, it's a tool where you often don't want to start medicine, and parents want other alternatives, and you have such a possibility of a profound impact on their whole life by treating them at a young age. And so again, I always knew it was a part of my practice. The cranial, I didn't really know anything about cranial when I started osteopathic medical school. I knew about OMT in general, but not the cranial. Um, but I think it was actually during my first year when I was exposed to it. I went to Western University and we had a full 40-hour intro to cranial course in our second year as part of our curriculum. So that was where I really got exposed. But I did some like SAO workshops and things like that over throughout my first year. And I was sort of an OMT nerd and hung out with those people and the TAs in the class above me and our OMM fellows. And so I was aware of this and hearing all about it. But I actually never heard anyone talk about it in kids. And so really, I learned about that when I was introduced to Viola Fryman. Um, and that was in my first year of medical school. I went down and did a one-day workshop at the Osteopathic Center for Children in San Diego. She was not working much at that point in her career. It was towards the end of her career. Um, but I had the privilege of being there that day with her and just got to briefly interact with her. But it left a profound impact on me to see that someone had made a career out of pediatric osteopathy, and then especially hearing about the cranial side of it. And that was really what started piquing my curiosity of, I know this is cool. I know we can do fun things with it. I know it's great for patients, but what can I really do in peds? Because again, prior to that, I had not heard many people talk about it.
So it sounds like this experience really piqued your interest in cranial OMM. How did you take that experience and run with it? Like, was there more stuff you tried to do to learn more about cranial and like approach it moving forward?
Yeah. So again, after that, it sort of piqued my curiosity, but I was a busy first year med student. There wasn't a ton of time to explore it. Like I said, I went to every SAO workshop I could and went to convocation and, soaked up everything that I could, but really dove into it in second year again when we did that course. And having that 40-hour course forever changed my career. And I felt fortunate I was one of very few schools at that time, and I don't know if there are any left at all that are doing the full 40-hour intro course within their curriculum. Um, but I had heard so much about, oh, you probably won't be able to palpate things your first time doing this, or, and it's a steep learning curve and you've got to be patient and, it's going to take years to do much with this. But that week I had really profound experiences that I felt and experienced both with me treating and with me being patient that was like, okay, there's something here. Also, around that time, I was a patient in our OMM Fellows Clinic. This was actually before the intro course, but I had a history of epilepsy. And in that in the OMM Fellows Clinic, they said, we found this dysfunction in you, which was an SBS compression, which I had no idea what they were talking about at the time. But for those who don't know or haven't taken it, it's the SBS is the sphenobasilar synchondrosis, which is the major joint in the skull. And it's the connection between occiput and sphenoid. And they said, this is actually really common in people with seizures and things like that. Can we treat it on you? But it was an intraoral technique. And so this was my first time like really, really understanding, okay, this can do some really interesting things. And they treated me and I felt completely different afterwards. And knock on wood, it's been 21 years since my last seizure. Was that treatment what changed it? I don't know, but coincidentally and time-wise, I think it definitely played a role. And again, learning about Viola Fryman, so she was actually a student of Sutherland. So she was really getting cranial osteopathy in its roots and at its foundation. And she treated a lot of children with seizures and similar neurologic issues. And so, again, I think it was a constellation of things that sort of led me down this pathway.
Oh, that's actually really cool. Can you describe your approach now that you actually use it? How do you use cranial OMM in newborns and infants or at any age of that childhood development?
Yeah, so I use cranial osteopathy in all of my patients, but especially right now, I'm actually the principal investigator on a clinical trial called the opt-in trial, which stands for the Osteopathic Plagiocephaly Treatment in Infants and Neonates. And it's run out of Viola Fryman's Osteopathy's Promise to Children, which is one of her nonprofit foundations. And so with those children, plagiocephaly, again, for those listening who aren't aware, is the flat heads in infants and the asymmetry that infants get, sometimes due to torticollis, sometimes due to prolonged positioning in either a crib or a bassinet or a car seat or a swing or things like that. And so with them, I think it's very obvious how I use cranial because I literally, their skulls are over 30 bones at birth, and many of those bones are still in separate pieces. So sphenoid is in 3 pieces, occiput in 4, temporals are each in 3 pieces, mandible still in 2. There's still 2 distinct frontal bones. So they have all of these bones and all of these junctions where things can shift and be deformed and lead to that asymmetry. And that asymmetry then can lead to impinging on nerves, on vasculature, on lymphatics, etc. And so they influence far beyond the cosmetic aspect of the plagiocephaly. But again, they have such unique and malleable skulls that literally I am in there moving and shifting bones just like we do elsewhere in the body when we think about, treating a vertebral dysfunction and moving that joint or treating a rib that's displaced, I'm doing that, but to the head. And so it's very different than when a lot of people think about cranial in adults, where the shifts are not often that dramatic, because the skull joints have much less mobility than they do in an infant skull, of course. I've used cranial osteopathy in infants as well to treat lots of feeding dysfunction, especially breastfeeding dysfunction, colic, reflux, torticollis. And again, all of that goes back to the shifts in those bones impinging on those nerves. So for example, if you've got a flattening on the occiput and it shifts everything anteriorly, well, in between that developing occiput and the developing temporal bone where your ear is, you get the jugular foramen that's developing. And in there are cranial nerves 9, 10, and 11. So that's glossopharyngeal, which is going to contribute to feeding, to choking, to swallowing, those types of issues. You've got 10, which is vagus, which has a far-reaching impact, as we know, but those are the kids who are fussy and colicky. Often I find that vagus irritated. And they're the kids who spit up a ton because vagus is innervating the gastroesophageal reflex. The gastroesophageal sphincter. And then you have cranial nerve 11, which is your spinal accessory innervating SCM and trapezius. So that's why torticollis goes hand in hand. And so again, when you really know this anatomy and understand this anatomy, it's very clear and very direct. And again, for me, much less abstract than learning cranial in the adult model, where you can get these same changes and you can treat similar adult versions of these types of symptoms. But again, in children where everything is so patent, it feels very different and works very different, and the impact can be incredibly profound. But I use cranial at all ages of life, and in my toddlers, I do a ton with treating otitis media, recurrent ear infections, sinusitis, the babies who have clogged tear ducts at birth. I treat as they get bigger. I treat behavioral problems, ADHD, sleep issues, mood disorders, especially anxiety, depression. I've treated and done studies and research looking at treating children with autism spectrum disorder and gotten amazing results with that population. And the other place I really use it in adolescents and teens are those with sports injuries, specifically concussions. And so again, it's something that is a big part of all of my treatments, and I integrate it in. And not even when I'm not directly working on a head, I am usually tapping into the PRM, or primary respiratory mechanism, which is a big part of that cranial model. And again, for those who aren't listening and aren't familiar with it, it's an underlying rhythm that's one of the components of that cranial osteopathy. So you can feel that movement and that motion, that rhythm from everywhere in the body, and it can be a sign of the patient's vitality and how they're doing as a whole. And so for me, I integrate it into all of my treatments.
So there's a really broad spectrum of what you can use it for, sounds like it. When you're
Yep.
talking about treatment, can you tell us a little bit more of like what are you feeling or moving? Obviously, you're not doing muscle energy or HVLA to the skull, but like what is it myofascial release, or what is exactly are you doing, especially for those who are not aware of all the different OMM treatment?
Yeah, great question. So some of it is just cranial, where we think about osteopathic cranial manipulative medicine or cranial osteopathy or osteopathy in the cranial field. There's different terminologies out there for it. But some of the things that I'm doing are technically techniques that fall under that modality, such as a venous sinus drainage, which is a technique designed to help drain all the different venous sinuses within the skull, or a CV4, which is compression of the fourth ventricle. So there's techniques like that that are specifically under that category. But the other big one that I use, and I use a lot in infants, is something called BMT, which is balanced membranous tension. So many students will learn about BLT, which is balanced ligamentous tension, which is everywhere else in the body you're balancing that tension, but it's ligaments. But in the skull, you can balance tension of the different membranes, the different dural membranes. And so I use that a lot in my treatment with these little ones. And that's what helps me sort of know how far to go with my motions, and where am I shifting and moving things, and when do I find that point of balance where everything just feels happy and is working the way it should.
Got it. And then it sounds like you have treated people, kids at different ages, from infant to like teenager years and all in between. Do you find that there's a specific window or a specific age where cranial system is most responsive to those treatment, or really at any age?
Yeah, any age, absolutely any age. But having treated throughout the lifetime, I think the younger you get them, the better. Because again, there's this saying for pediatric osteopathy that sums up what I do, in my opinion, which is as the twig is bent, so grows the tree. Meaning, if there's a dysfunction there that you don't address, you don't treat, it gets left there. And if it gets left there, so for example, say the plagiocephaly or the torticollis, the body develops compensation around it. Um, and and that goes throughout the whole body, right? Because it's not, nothing is just isolated. We know that as DOs with our philosophy and how we think about it. The body's a whole. And so for me, the younger I get them, the better. And obviously, when you look at the skull of an infant that's wide open with patent sutures and so many ways to create change in this malleable structure, it's very different than treating an adult or a big kid. That being said, one of the other treatments for plagiocephaly is helmets. And part of what we're seeking to show with our study is that we are, in my opinion, of course I'm biased, but the better option for treating plagiocephaly than that for a number of reasons. And what's happening with that is they're applying pressure in a constant position and the skull is moving around that. But they refuse to place a helmet over the age of 1 because they say no change will happen in the skull over the age of 1 with a helmet. The oldest kid I have documented change on is a 3-year-old. He was a patient of mine at my former practice at Nationwide Children's Hospital, and he was seeing the craniofacial clinic because he'd had plagiocephaly as an infant, and they were following him sequentially because they knew he still had asymmetry and deciding if he needed perhaps a surgical intervention at some point. And he was being seen every 6 months to a year for monitoring. And one time they went in after they started seeing me, and the family came and I was like, I don't know if I can get change, but I think that I can. Everything is still patent. It's still a 3-year-old has a lot of room to grow and things are still pretty open. So I said, I'm willing to try. And when they took his cranial measurements, they were pretty blown away that he'd had as much change as he had once I'd started treating him. But I've also seen shifts like that in adults that I've treated, where their facial structure can change and things, especially if they've had a history of trauma. And so there's really no age that's too old that you can't make an impact. But of course, when they're so young and fluid, it's easier to make that impact.
So it sounds like you really can use cranial OMM in a lot of ways to help a lot of patients at different ages. But unfortunately, there's still some controversial around cranial OMM, sometimes even among osteopathic physicians who use manipulation in day-to-day practice. Why do you think it's met with such a skepticism, and how can we address this as a clinician, educator, researcher, students? How can we help getting the stigma away?
That is a great question. And for me, I don't understand why there's so much stigma and so much mystery around it, because to me, it is very much anatomy and physiology. Um, and I do think, again, it's easier to understand with kids. Like, there's no one that will argue that an infant's skull doesn't move, right? We see molding of a newborn skull after delivery. We know they have that capacity. Plagiocephaly exists because they have the ability to change the shape of the head, and it cracks me up that, again, people think that exists and they don't deny that, but then they don't think that I can create change with it. So one of the things that I really think in general our profession needs, but especially the field of cranial osteopathy, is more high quality evidence-based osteopathic research, specifically OMT research. I actually started on the other episode. What we talked about was the Conference on Osteopathic Research and Knowledge, or CORK, which I co-founded with Dr. Jordan Keys. And that's committed to connecting those people who want to do higher quality osteopathic research so that we can support each other, mentor each other, share resources, collaborate on multi-center studies in the future, all of those types of things. But that's part of why when I designed my plagiocephaly study, one of the things that we're doing that's really unique versus the other studies, there's actually, I think, 10 or 11 now published studies out there on OMT and plagiocephaly. It's one of the better studied conditions, but one of the part of our study design that I think is really unique is that we are taking measurements of the cranial vault asymmetry index, which is a measure of the actual head shape and how much asymmetry there is, not only week to week as they're getting treated, but I take a pre-OMT image and a post-OMT image. And so literally no one can tell me it's a placebo effect because we've shown that doesn't exist through research in infants, but also you can't really placebo affect a head shape. Um, everyone argues with me, it would have gotten better on its own over time. They tell me that you're not actually moving cranial bones. You can't do that. And we have shown with our data we're at about 25% in completion. So it's still early and we're waiting on all our final data, but on multiple occasions with multiple different doctors treating, we have shown a greater than 50% change, up to a 90% change in that cranial vault asymmetry index with a single OMT treatment in between. And so this is how we prove it. There's also scientists outside of our profession doing this work and proving it for us. So for example, in Japan, they're using functional MRI and capturing CSF movement. And previously, if you remember, you were taught CSF moved in that lovely diagram with you can follow the arrows all around and trace the pathway, and it looks like a flowing river. But on MRI now, they've actually shown that CSF pulses and moves like we've been describing it for over 100 years. So technology is catching up in ways that I think is really going to help us explain, capture, and solidify what we're doing with this work. They're also doing studies on CSF and finding you know, new hormones and new signaling cells and things like that, that again, the impact is bigger than we ever knew. The glymphatic system I wasn't even taught about it when I was in med school because it had not been discovered, but that's the lymphatic system for the CNS. And it makes sense that that's a lot of what we're influencing, and that's why we get some of these more profound changes. Some of the other cranial research that's really impactful comes from NASA. They've shown that the skull bones move, and that's published again outside of our field. That's not us claiming it. We also have within our field some research taking place on rodent models about cranial that's really starting to elucidate some of the efficacy and the mechanism. Dr. Hope Toby out of VCOM, she's another pediatrician, and she got asked to do this study treating rats with cranial because she treats small kids. And so they said she was the closest. But she did a CV4 on rats once a day for a week, I believe. And then they looked at the rats' learning and memory, and they were able to do a water maze quicker after they got treated with the cranial. They had better memory, and they were rats with Alzheimer's. And afterwards, they sacrificed them, and they have studied them, and they found decreased polymer plaques. They had increased monomer plaques. They had increased aquaporin pores after treatment. And then they did a follow-up study, and don't quote me on this exactly, but they basically showed that when they sequenced the DNA, there were DNA and like epigenetic changes happening after treatment in those rats. So again, it goes and supports what we've known for years, those of us doing it, what we've seen in our clinic, that this goes beyond a physical change. There's more happening, that it's harder to quantify, harder to explain, but it's there. And so starting to see some of this imaging, and the biomarkers and things like that, we're going to have a better idea of what we're doing in the future.
So the future is OMM research, basically, really showing everyone else that actually it works.
Absolutely. Absolutely.
Awesome.
Absolutely. That's what our patients want. That's what we as a field want. That's what our allopathic colleagues want, other healthcare professionals who are referring to us. And so it's time that our profession step up and do that and work towards that.
Yeah, absolutely. So outside of your clinical work, you also have roles at Touro University, California. Can you tell us a little bit about your current roles there? What do you do?
Yeah, so I've been at Touro for 8 years now, and I'm a professor in the OMM department, so faculty exclusively in the OMM department. I do teach some pediatrics and some of our, especially for our third and fourth years, I work with them. But most of my work is in the OMM department and that curriculum. And I also have the privilege of being the director of pediatric OMM there, which has helped empower me to go out and do more learning, more mentoring in this area, taken additional CME courses, so different educational courses, do my research work, all of that under that guise of that's my title. This is what I'm here to work on and advance and share about. So it's been fun to do that.
Cool. So what advice would you give your osteopathic medical student who wants to build a stronger foundation in osteopathy and especially the cranial field during their time during medical school or in residency? Is there specific resources or advice you would give them?
Yeah, so get your hands on. You need to get your hands on, and you can have a really strong foundation in all of the other OMT if that's what's mainly offered at your campus and there's not as much opportunity to get the cranial. The better your hands are at palpating everything, the better they will be when you go to try and palpate and take that and carry that skill into learning your cranial osteopathy. But even as you begin to learn cranial osteopathy, it's a tricky palpatory skill that you've got to build. And so some people get frustrated with that. But if you remember back to the beginning of first year, you couldn't find a transverse process. And now that's really easy. And so again, it's just like that. You have to retrain your nervous system. You're recalibrating and tuning into something different. And so just be patient as you learn it and practice as you learn it. I strongly, strongly suggest working with people who are using it in practice so you get to see it and ideally feel it. So shadowing or rotation opportunities, if you've got that as an option in third and fourth year. Um, I highly recommend you get treated with it yourself because again, that changed my mind. And there was actually a recent article that came out in the Journal of Osteopathic Medicine talking about that one of the biggest indicators of who uses OMT in practice is those who treated and got treated outside of the lab. In the lab, when you're learning this in first and second year, you're treating mostly healthy relatively young people without a specific issue that and addressing it with okay, today we're doing thoracic HVLA, whether or not that's your problem. So you don't really see the profound impact of what happens when you actually treat a sick patient who has the dysfunction that you need to address. And so get your hands on that. I highly recommend taking the full 40-hour intro to cranial course. There's the Sutherland Cranial Teaching Foundation has one. The Osteopathic Cranial Academy has one, and we have one out of Osteopathy's Promise to Children. I will, of course, pitch for that one since I'm part of the faculty for that one. But I will say that if anyone is interested in pediatrics, obviously coming to Osteopathy's Promise to Children, all of our faculty worked closely with Dr. Viola Fryman. And we started last year, in addition to having 2 hours of a pediatric cranial lecture, we added on a 2-hour pediatric cranial lab into our course and shifted some of the other content. So again, if if that's an area you're interested in, come visit us in San Diego for that. We offer ours in July. Um, but there's lots of great courses out there through a variety of organizations. The Cranial Academy does have really great hybrid options where you, instead of taking the full 40 hours in a classroom, you're able to do some previewed videos and get the didactic content and then come together, I think, for 2 or 3 days of in-person learning. So sometimes that's more manageable as a student when you have a busy schedule. But just know there's lots of different ways out there. There's scholarships available. So again, if those are ever concerns, reach out to the organizations you're interested in working with. Um, but yeah, come take that. I'm biased and love the 40 hours in person. The hybrid is great because, again, it's often more manageable, but the 40 hours in person and building that skill day in and day out for 5 days in a row and having that concentrated time, we see such a huge difference in what people are able to palpate from day one to day five. And so that's just one plug for why that model might be better for some people.
So part 2 of our conversation was Dr. Kim Wolf. So let's switch gear and talk a little bit about your journey. Where did you grow up, and I know we talked a little bit about what got you interested in OMM, but what got you interested in pursuing medicine as a career in general?
Yeah, so I grew up in Columbus, Ohio, and at 4 years old, I very distinctly remember going to who I thought was a pediatrician. Turns out she's actually a family med doc, but as a kid, she saw kids and thought she was a kid doctor. Um, but she gave me a book when I was 4 years old on Elizabeth Blackwell, and Elizabeth Blackwell was the first female physician in the United States. And my little 4-year-old feminist self said, if she can do it, so can I. And I didn't really understand the fact that she'd been doing that for a long time, that had happened a long time ago. But that sort of really sparked my interest. And I told my mom at 4 years old I'd be a pediatrician. So here I am. Um, but of course, over time, that only strengthened with other experiences and life lessons. And specifically, I knew I wanted to go into osteopathic medicine because of my mother. She has multiple sclerosis and MS. Her MS symptoms really, the thing that made the most significant change and difference for her was OMT. And so as I was applying to med school, she said, I think you really need to look into DO schools. And I was like, okay, I'll look. And as soon as I did, I was hooked. I knew that the philosophy really aligned with who I was. And again, wanting to be in pediatrics, I loved the idea of having this extra modality to help people that wasn't a pharmacologic option. And so yeah, here I am doing peds OMT.
Awesome. So was there also any experiences that inspired you during undergrad, and which undergrad school did you attend before medical school?
I went to undergrad at Seton Hall, which is in New Jersey, and one of the most profound things that happened to me in high school and into college was the diagnosis of epilepsy. So I was diagnosed right before I went away to college. Um, but my experience as a patient, I think, and especially being a pediatric patient at the time of diagnosis, really changed and shaped who I was and how I wanted to practice medicine in the future. It changed how I communicated with not only families but with patients themselves and include them in discussions and things like that. Um, and I just some of the doctors that treated me, I never want my patients to feel that way when they see me. Um, an example of that was when I was actually diagnosed with epilepsy, my very first seizure. I was alone at a camp in high school for kids who wanted to go into medicine. And so I was taken by ambulance to a hospital after and was all by myself there. And the neurologist walked in and saw my birthmark. For those who can't see, I have a nevus spillis on my axilla. And she, without even really introducing herself, just grabbed my shoulder and said, "What is this?" And I said, "A birthmark." And she said, "Well, it might be related to your epilepsy," and didn't explain it any more than that. And then again, I was, 16 years old, and she said, "By the way, you have epilepsy and you're probably never going to drive again," which at 16 years old, sitting there completely alone, was devastating on so many levels. And so, again, I never want my patients to feel like that. I never want their families to feel like that. And so those are some of the most impactful situations. And again, I know that was more high school than college, but it continued into college as being a patient yourself, and especially with a chronic illness, those encounters shape who you are and how you practice in the future.
Yeah, so it really sounds like your personal experiences, your own and your mom, kind of what led you to medicine and osteopathic medicine as well. What was your experience at your school? Did you do any extracurricular activity other than the OMM aspect, like research at that time, that led you kind of into that career as well?
Yeah, as I said, I went to med school at Western University. There was only one at the time, which was in Pomona. I'm old. Um, and so I was really active with UAAO, which is, again, I'm old. It's now SAAO, but it used to be the Undergraduate Academy, American Academy of Osteopathy. So I was really active with them and then with our PEDS organizations on campus. I did a lot of volunteer work, but I no no research at all. Um, I never wanted to be a researcher. And so, again, it's funny to me how life has led me here, but being in the field and seeing the gap that existed, I knew that it was something I had to do. And so, um, and I've embraced it now. I love it and I see the value of it. And I, I figured out how to make it fun for me with it being clinical research. I love that. So I still get to see patients and I'm just doing what I do, but calling it a research study. And so there's been a lot of value in that for me. But um, no, in undergrad either, I had zero research experience until I was in residency. And interestingly enough, my very first poster was on plagiocephaly in residency. They were babies who had come to me in my continuity clinic as a resident, and they had plagiocephaly, and I had treated them. And one of them had a really cool growth curve where the kid was like failing to thrive, and then we are all of a sudden started treating, and the weight shot up, which was again because they were feeding better and spitting up less. And I was like, wow, this is cool. And then my other kid was one who'd had the head circumference was, it kept rising really high, but the kid had had an negative workup for why that was happening. But it was just the abnormal head shape from the plagiocephaly. And so as we treated, you could see the head circumference normalize and stabilize. And so that first poster, I had those two case studies on there to show like this is pretty cool what we can do. And so that was my first time my interest was really piqued into how do we quantify this? How do we show others what we're doing?
And then speaking of residency, what was the application process for you? How did you choose the programs to apply to? Was osteopathic recognition at that point really important to you, or you applied kind of everywhere?
Osteopathic recognition did not exist because I'm old. So I applied at the time when there were actually two matches. There was an osteopathic match and an allopathic match. Um, I I knew that I needed to be at a program that would let me practice OMT. My ideal would be a program where I could continue didactics and especially in the field of pediatrics. And so all of my fourth year rotations, my OA rotations and sub-Is were at institutions that had an AOA accredited program, which is essentially the equivalent now of the osteopathic recognition. And I actually, like I said, I had gone to undergrad in New Jersey, and so I thought I wanted to be back out on the East Coast. I had loved that coast and still had a ton of friends out there. So I was looking at different programs out there, and one of the places I rotated, I wanted to treat a kid. It was a 2-year-old with neck pain, and they said, no one here is accredited to do OMM. And I was like, but you have an AOA accredited residency. Your residency program director is a DO. I don't understand. And funny enough, I was rotating at the time with another woman who, I was venting to her about it and saying, I don't understand. All I want is to treat people, and we have this skill, and why can't I do it? And she's like, oh, if you want to do OMT, you got to go look at Nationwide in Columbus, Ohio. And I laughed at her because I'm from Columbus, Ohio, and swore I would never go back to Ohio. I like the coasts. And then I went and that night and read about Nationwide and knew that that was where I was meant to be. It literally checked every box I had. They had a really extensive didactic program. They had an OMM rotation second year at the time. They had an annual OMM retreat where they brought in outside faculty. And so that was ended up being my number one choice. And as I said, at that time, there were 2 matches. And so I entered the osteopathic match, which actually took place a month before the MD match. And so I matched into Nationwide. And with that colleague, that woman, she's still a very, very dear friend. We were one of 4, we were 2 of the 4 people in our class for that osteopathic track at the bigger pediatric program there. That being said, today, I think what you really need to know is, can you put your hands on someone? Can you be somewhere where you do OMT? You may not have OMT faculty where you are who can specifically teach you, but the most important thing is keeping your hands in tune and using that skill and not losing it. So treat family and friends. My co-residents loved me because on call, I was always treating them in the call room. And so again, anything to kind of keep your hands tuned up. And then I went to Convo every single year in residency because that was my chance to really get an intensive hands-on experience, to talk to people doing this work, to see my mentors, and to kind of remember my commitment to wanting to do that work, wanting to integrate it into my practice. And then a lot of my other training has come with finding mentors, doing pediatric osteopathic focused educational courses and things like that. And so that being said, there's one program right now in pediatrics that has osteopathic recognition, which is Oklahoma State. And I hear wonderful things about them. I have a number of friends who graduated from that program. But there are a number of other hospitals where you can get pediatric OMT in residency. They just don't have the osteopathic recognition formally. But if that is important to you, don't compromise on it. And anyone is welcome to reach out to me if they can't find those programs. So track me down.
How is so you did the residency, you graduated. How is the process of finding a job after you're graduating? And are you still with that first practice, or did you consider private practice, or what was like kind of the track for you for your first job?
Yeah, great question. So when I finished residency, I actually was planning to do a +1 year in OMM, um, because again, during residency, I had mostly focused on the pediatric side. You're busy in residency, you just don't get as much time to do that. And I was hoping to be able to do that year with one of my mentors. However, his +1 program was literally awaiting a signature from the AOA at the time that I graduated and wasn't ready. So I took a job at Nationwide Children's for a year, thinking, okay, next year I'll go out there. But with Nationwide Children's, they made me part of the residency faculty. And when I was in the residency program, it was a family practice doc who was teaching the OMT, and he didn't treat infants. He didn't like infants. And so they said, do you want to run that side of things? And so I took over the didactics for our peds residents. And I took over, we had a peds OMM clinic, which was 1/2 day a week. And they said, we'll see if you can fill it, because he had never filled it, because he, again, wasn't really a pediatrician. He wasn't invested in that population. It was sort of one piece of his role. And I had I filled that 1/2 day very quickly. By the time the 1 year mark came around, I was up to, I think, 3 half days at that point of OMT clinic, because the demand was so high. And I realized if I walked away from that to go do the training, I would actually be seeing less pediatric patients than I was in my practice. So I opted to stay at Nationwide, and I was practicing as a general pediatrician and then peds OMT clinic. And by the time I left, I was there for 4 years. I had 3 full days of peds OMT clinic and a year-long wait list to get in to see me. So people want this, especially in pediatrics. I never advertised. That was all like word of mouth. And I got referrals from a number of people within our hospital. I was doing that within an FQHC within Nationwide Children's Hospital. So again, these options are out there for everyone. And then I also actually during that time became the PEDS residency program director. And we were the first pediatric program in the country at the time to receive osteopathic recognition under ACGME. And so I got to serve in that role for a while. So again, I'm familiar with it, even though I didn't, it wasn't an option for me. And then I stayed at Nationwide for 4 years, and then I went off to Touro. And a big part of why I switched from graduate medical education or residency down to undergraduate medical education or med school level was I found out by the time they got to residency, if they had not been using OMT, they had already lost that interest, lost those skills. And so my hope and intention was to inspire them earlier and motivate them earlier and show them the value in it. And so that was what inspired that change.
Awesome. So our grand finale question that we ask all of our guests, what was the best piece of advice you got throughout your education, can be from growing up, college, medical school, or residency, that you always think of and would like to pass it on to other students?
I think one of the most important pieces of advice is do what you love. And I especially talk about this with my mentees as they're going into 3rd and 4th year and thinking about residency. Especially the ones who are undecided. You're gonna like a lot of different rotations because this is the field you chose. You chose medicine, and things are going to be interesting. But where are you energized? Where do you come home every day wanting more? Where do you wake up every morning eager to return to the hospital and see these patients and learn more? Where, you will notice during those times people in your life are going to say, "Hey, your smile's back, your energy's back. I've seen you more this month," where versus there are months that, again, they're fascinating while you're there doing it, but at the end of the day, you're just sort of drained from it. Because it hits differently with you. And I think that becomes important with, also which residency program fits right, as you get a feel for it. Don't just pick the one that looks the best on paper or, the one you think you should, but where do you resonate with the people there? As you pick a job, pick one that doesn't just pay the bills, but one that in some way nurtures the rest of you, and that may not be through the job itself. The job may not be perfect as you're figuring that out, but joining organizations, joining societies that match your interests and feed you and connect you with people who want what you want in this career. So that would be one of the biggest things, is just keep that in mind and be true to yourself and who you are, because life is too short not to be.
Awesome. Well, thank you so much for doing this episode with us. I learned a ton. I hope our listeners also learned a ton today. Thank you for being with us.
Thank you so much for having me.
This concludes our episode of Do or Do Not. Send all inquiries, comments, suggestions, and even let us know if there's someone you want us to interview to doordonotpodcast@gmail.com. Don't forget to like us on Facebook at Do or Do Not Podcast for updates. If you enjoyed our podcast, please share it with your classmates and administration. We have plenty of more interviews lined up, and we're excited to share them with you. This is Tian Yu Shea. Thank you guys so much for listening to Do or Do Not.